Thank you, Devoya, and good afternoon, everyone. Thank you for welcoming and do all the good housekeeping. And I just wanted to welcome everyone here. I don't see any new faces. It's most likely we have the same participant. So I'd like to welcome to Holistic Culture and Education Wellness Center. My name is Samnang Heng. I am one of the cultural broker here representing various underserved community here in Central Valley. If this is your first time, if you've been here before, that's fine. But we just like to welcome everyone. And then we are Holistic Center is a program from Fresno Department of Behavioral Health. We operated by the Fresno Center. We provide culturally and linguistically appropriate education, training, and linkage service to underserved and unserved individual and family who may not typically seek traditional Western clinical-based mental health services. We are funded through the Mental Health Service Act Prop 63 and have been providing options such as today workshop for almost 9 to 10, I think close to almost 10 years. March, in honor the month of March is the National Women's National Days. I wanted to share a brief mental health message fact that I do a study, and this is from Dr. Gunter, and he said depression disorder account for close to 41.9% of the disability from neurological psychiatric disorder among women compared to 29.3% among men. A mood disorder is a mental health class that health professionals use to broadly describe all types of depression and bipolar disorder. Children and teens and adults can have mood disorder. However, children and teens don't always have the same symptom as adults. It is harder to diagnose mood disorder in children because they aren't always able to express how they feel. So therapies, antidepressant, and support and self-care can help treat mood disorder. What are the different types of mood disorder? We'll pause there and let Dr. Ngo will answer you when he's doing his presentation. But before he do that, I just want to make sure that everyone's please complete the surveys and also have your question in the chat box, okay? And this is our third installment of mental health workshop. So I want you to know that we have this until June. So please help promote and help invite your participant to this workshop for the next month if they are unable to come this month. So for without ado, I would just like to welcome Dr. Ngo, who is our presenter. He's been with us for several times already. So please welcome Dr. Ngo.
Okay, thank you, Samnang, for the introduction. So the topic for this month is understanding mood disorder, and that's gonna be it's a pretty broad topic, and it's obviously a bread and butter for mental health and for psychiatry as well. So I'm gonna try to I have to scale down a little bit some of my presentation because I didn't want to make it too technical. So when I give presentation, I have to remember the audience I'm speaking to or giving a presentation to, whether it's medical students, other mental health professionals per se who are actively treating patients, whether psychologists, social workers, etc., or just people in the community, professionals who are involved in community activities, try to promote mental health, and certainly seeing clients or patients with multiple mental health issues at the same time while doing community outreach. So with that being said, let me get started. So some of it's going to be a review from the last time, and some of it's going to be new, but I'm going to start with depression first, or major depression, and then when I transition to bipolar disorder. And because some of the symptoms are included in both illnesses, and certainly to be diagnosed with bipolar illness, one has to meet criteria for some form of depressive disorder as well. So the first thing I wanted to differentiate, and I did this my last presentation, is differentiate depression from sadness. So sadness is, again, a normal emotion, but everybody will experience at some point of their life, and we all experience sadness. It's just part of a human emotions. However, sadness is usually triggered or identified from a specific situation, person, or event. So some of us, many of us, have experienced sadness from stressors such as loss of employment, relationship breakup, death of a loved one, bereavement, etc. So that's just a normal symptoms. However, sadness is just one of many symptoms of depression. And I'm going to go over some of the criteria for depression. Usually in sadness, the severity of the symptoms are not profound or cause impairment in functioning, and certainly they do not cause people to have thought of self-harm or suicide. So that's a major, in mental illness, and I always like to give equivalent, but for a cardiologist, a heart attack or myocardial infarction is sort of the emergency for cardiologists. For mental health and for psychiatrists, it is a suicide. So suicidal thoughts is our heart attack, is our emergency, where we have to address as far as safety for the patient and the well-being of the patient altogether. So to differentiate sadness with depression, usually depression, although it can be caused by a life stressor, usually there's no trigger. So somebody could get into starts showing sign of depression even without a specific trigger or life stressor that has happened. It tends to be more profound and expensive, meaning by the number of symptoms or the intensity of the symptoms. So a person may feel just sad and hopeless about everything, not just one specific thing but everything in their life may bring sadness. The hallmark symptoms of depression is sad mood and what we call anhedonia, which means a loss of the ability to experience joy or pleasure, or to engage in activities that one used to derive pleasure or joy from doing. So, for example, if somebody enjoys going out with the family, going to movies, and for a depressed patient, one may not even bring themselves to enjoy activities that previously we used to enjoy when in a non-depressed state. And there are many other associated symptoms per DSM-5, the Diagnostic Statistical Manual, that's sort of the manual we use in mental health to diagnose any mental health disorder. So I'm going to go over those diagnoses and criteria for major depression and other depression as well. But remember that depression can affect every state of one person, including one emotions, the thinking, the behaviors, not just mentally, but physically. And we talked about how mental and physical state can intertwine and affect each other in previous sessions. So certainly it affects all capacity of one being and one functioning. The difference between depression and sadness lies in the context of where it occurs, the severity, and the number of accompanying symptoms, and the duration, as I'm going to specify in the DSM-5 diagnosis. One of the main things with depression, usually compared to sadness, usually to diagnose somebody with a major depressive illness and not just sadness or minor depression, one has to experience significant impairment in functioning in multiple areas of their life. So not just, it could be at school, it could be at work, it could be their family. So usually when I inquire about depression, I want to sort of see how it affects the patients in multiple areas. So how do they function at work? Are they able to get up in the morning and carry on with their days? Are they able to get at work? Are they able to, if one is able to carry on their family obligation day to day? How does one interact day to day with their significant others or friends or not? And again, you know, usually with depression, as opposed to sadness, the end point is thought of self-harm or suicidal thoughts, and somebody attempt that we are gauging and constantly assessing or evaluating patient for. So these are the criteria for major depressive disorder per the DSM-5 diagnosis manual. So the individual must experience 5 or more of the following symptoms for the same 2 weeks period. And usually those symptoms have to be present most days than not. So it doesn't have to be all the same symptoms every day, but certainly there has to be enough symptoms for the whole duration of the 2 weeks period. Those symptoms have to include the depressed mood and anhedonia, which is loss of interest and pleasure. So those 2 symptoms have to be met to even consider diagnosing somebody and treating somebody for a major depressive illness. Again, it has to include depressed mood most of the day, nearly every day for a period of 2 weeks. Diminished interest or pleasure, which what we call anhedonia, in almost all activities and mostly every day. There has to be a change of, there can be a change in weight, whether it's weight loss, which is more common, but also a weight gain. It can go either way. Some people with depression can tend to eat more to sort of fill the emotional void or make themselves feel better. And we all experience that to some degree as far as emotional eating. Or some people may lose the appetite and not want to eat and lose significant amount of weight, which is a red flag for psychiatrists or mental health professional to if a patient has lost significant amount of weight in a short period of time, certainly we're gonna question that into the bigger picture of the severity of the depression. The next criteria is slowing down of thoughts or reduction in physical movement. So when you think about a patient who's severely depressed, it tends to move slowly and they tend to sort of have sort of a reduction of a poverty of speech. They don't want to talk, or the way they talk tends to be sort of slowed down. And that's also mirrored in their physical movement. So they tend to sort of, move slowly, get up slowly. It's what we call a psychomotor retardation in psychiatry. When we do a physical exam or a mental status exam, I do describe whether a patient is has psychomotor retardation or agitation. Some patients who are depressed can also present as agitated, but that's usually the exception rather than the norm. Fatigue or loss of energy. So a lot of patients who are depressed complain of feeling fatigued, very tired, have no energy or very little energy to do things daily. Feeling of worthlessness or excessive or inappropriate guilt. It's not just worthlessness. I always ask about hopelessness and helplessness as well as worthlessness. So the way I ask worthlessness is, do you ever think that, life is not worth living, or whether sometimes you're not good enough? Or hopelessness, do you ever feel that, the way you feel now, there's no hope for you in the future? Where do you see yourself in a month or in a year? And a lot of patients who are depressed can't see beyond or have hope or be future oriented in their response. Also helplessness, do you feel yourself that you be able to reach for help, or do you feel that there's a solution or help for you with the way you feel now? And a lot of patients says, no, I feel that my case is nobody can help me. What's the point of reaching out, because my case cannot be helped. The next criteria is a difficulty or diminished ability to concentrate, or sort of indecisiveness. So a lot of patients who have a major depressive illness or episode have a hard time concentrating. So they have a hard time thinking, putting their thoughts together, thinking, concentrating, whether it's reading a book or doing their work at their job or perform a certain task. So it does impair concentration. And a lot of them have a hard time making decisions. For most of us, we decide automatically to get up in the morning, to go to work, brush our teeth. Some of these things is a struggle for very depressed patients. Should I get up? Should I go to work? Should I, do I need to do things? Even though they know very well they have that responsibility, they sort of indecisive in making that automatic choice that normally they would make in a non-depressed state. And there's usually recurrent suicidal ideation of thoughts. And certainly I assess for suicidal ideation on every interview, every encounter that I have with patients in every evaluation. More than that, I'm very specific on just not thoughts. If there is even a remote, so I ask usually, have you ever thought about giving up on life? Or worse than that, have you ever had thoughts about harming yourself or about suicide? If it's a yes, or even if the response is equivocal, I'm going to proceed and ask them, have more than ideation, more than thoughts, have you specifically ever made a plan towards it? And obviously, have you ever made any attempts to commit suicide? And that has to be screened on every patient. I don't do it on an established patient, but certainly every patient on new evaluation, I do a suicide risk assessment for every patient, whether I'm screening for depression or it's part of a psychiatric interview. And a good clinician should be screened, mental health clinician should be screening for suicide on every encounter. Because that's a heart attack as far as an emergency for psychiatry or for mental health. And again, a lot of these symptoms have to cause the individual's clinically significant distress or impairment in many areas of their functioning. Again, whether it's social, occupational, at work, or in the family, or with friends, it's usually throughout multiple areas and not just one area that's affected. And again, to be diagnosed with major depression, usually we need to screen to make sure there's no substance use that's confounding the presentation of the patient. Because as we know, and many substances can affect mental illness, and certainly can affect depression or can precipitate a depressed state for many patients. So part of my psychiatric interview as well, I always screen for substance use. How recent has it been? Even if the patient has not used alcohol, even alcohol, which is a depressant, or any other drugs, whether they're actually using or withdrawing from certain drugs, I always screen for it, even if they have been sober or quote unquote clean from or not using any illicit substances such as methamphetamine, cocaine, or heroin, or any other illicit substances. I know very well that those illicit substances can long-term affect the person's ability to think, to feel, and to behave certain ways. So, and like I've said before, there's a mnemonic that I tend to remember to ask my patients when I screen for depression, and that is SIGI-CAP, which is I always ask for sleep, for interest or lack of interest, or anhedonia, guilt, excessive guilt, energy, low energy, concentration or lack of, appetite, usually decreased, but sometimes increased, and psychomotor retardation, which is the P in SIGI-CAP. So I do this every day in my work, so I don't necessarily remember this mnemonic. I automatically know how to screen patient and ask about every one of these symptoms, if not more. So now that I've covered the DSM-5 criteria for major depression, let me sort of take a side note on the clinical assessment, i.e. the subjective description, which is matched with elicited objective criteria. So what I mean by that, psychiatry and mental health, but psychiatry, I've always been asked, how do you, a lot of people have, and even medical providers have a hard time understanding how do we objectify symptoms. And certainly as far as criteria, how do you diagnose for sure, how do you know for sure a patient has major depression? Well, we have obviously the DSM-5 criteria to guide us, and those are criteria, but usually in my interview, the first thing I ask when assessing a patient for depression is, if the patient tells me, doc, I've been feeling depressed. So I will always ask before I go to my criteria, is tell me. So let's say Samnang was to tell me, I'm just not picking on you, Samnang, but Samnang came to my office and said, Dr. Ngo, I've been feeling very depressed. And my job is trying to understand where Samnang is coming from. So I would ask, okay, well, Samnang, tell me a little bit more about your depression. So I always leave it open-ended. So I'm never focused, because we don't want to make it mechanical and ask about every criteria, even though it's always in the back of my mind. But certainly as Samnang, tell me about your depression. And, whatever Samnang answers, and usually I ask, help me understand your depression. Describe to me what does it feel like to you subjectively? What's depression to you? What do you experience? What symptoms do you experience? So once I have a framework from the subjective standpoint, then I can sort of go to my objective criteria and see if those matches with what the patient is reporting to me. If they don't match, if there's elicit those symptoms. So let's say Samnang said, well, doc, I've been feeling depressed. The first thing I said, well, have you been depressed for more than 2 weeks? Nearly every day for more than 2 weeks, or it's transient, like it lasts a day or two and then you get better. So if someone says, I've been depressed for more, it lasted 2-3 weeks, I just couldn't get myself to get out of bed, I didn't go to work, I called out, and then he tells me, I haven't been having an appetite, and It's hard for me to concentrate or finish my project at work. So then I would ask, if that's already tells me, then I would ask for other symptoms. So, okay, Samnang, do you, besides what you told me, do you find yourself more tired than usual? Do you feel like you have no energy? Or, tell me something that you used to enjoy doing. Do you used to enjoy going out with your family, to event, to a baseball game, or whatever it is? Are you still doing that? Yes or no? So once the patient tells me the subjective report, now I'm going through the criteria and try to elicit symptoms to see if it reaches threshold for a DSM-5 diagnosis of major depression. Okay, let me go on for the sake of time. So major depression are the most common, major depression, mood disorder in general, are the most common psychiatric conditions in mental health. If you see here the pie chart on mental health, it includes almost half of mental health presentation or diagnosis. The lifetime prevalence of major depression in adult, it's usually 10 to 25% for women and 5 to 12% in men. In prepubertal children, before puberty or before they reach teenage years, usually boys tend to experience depression more so than girls. As adult, after age 18 up to age 50, usually women are twice, if not more, likely to experience depression than men. And after age 50, the rates almost equalize or equate between men and women. So some points on major depression. So the average age of unipolar depression, and I use the word unipolar because I'm going to contrast it to bipolar depression later on, which is the depression part of bipolar. So here we're just talking about major depression. Unipolar depression is 29 years old. It tends to increase significantly after puberty. The onset is usually gradual, not always. Sometimes you may have a precipitator or trigger. So let's say a death in the family. And then usually with bereavement is different for everybody. But usually, after a certain period of time, people should get better. If the symptoms get worse and continue to be significant and impact their impairment functioning, then major depression can be diagnosed. It's what we call double depression. So somebody gets sad or have bereavement and then progresses to major depression. But usually the onset is very gradual. So a patient may report usually, having a few symptoms, or all the family saying, hey, I'm just picking on Samnang now, but his wife would call me and say, hey, Dr. Ngo, I've noticed my husband is he doesn't sleep as much, or he's on weekends, he's sleeping like 10 or 12 hours. So that's one symptom. And then, she will report to me that I've noticed that also, when we ask him to go out to certain events, he's not taking the offer, or he doesn't want to do that anymore. So there's gradual onset of symptoms that sort of builds up usually over weeks to months, usually. So people don't usually get depressed overnight. There's usually a gradual development of symptoms. Some of the early signs could be insomnia or sleep problems, or whether it's sleeping too much or not sleeping enough, poor appetite, or the opposite. Some people tend to eat more when they're depressed, decreased concentration, loss of interest. But usually the symptoms are at sub-threshold level, meaning they don't cause significant impairment in functioning yet. Those are the early signs. Some other prodromal symptoms that are often found with depression or anxiety and panic attack. Anxiety and depression almost go hand to hand a lot of times. So obviously when I screen a patient for depression, I screen for all mental illness, including anxiety, as part of my evaluation. Major depression is usually considered a chronic and recurrent illness. So once somebody has an episode, one episode, the more episode one has, the more likely they are to experience another episode. So the risk of relapse or increases with every episode of depression. Full recovery usually is achieved within 6 months in half of the patient. That means the other half keep having recurrent episodes. I'm not going to go into details with multiple factors that could influence relapse, but usually if they had previous episode, the likely chance they have another episode of depression increases. For psychiatry, usually if they have not reached an adequate treatment with antidepressant for long enough, or at a dose at a significant dose that's clinically efficacious. Sometimes patients, a lot of times, they discontinue treatment, whether it is medication or therapy. That puts them at risk for relapsing. And a lot of times they may have other medical conditions, physical conditions that may cause them to relapse. A small proportion of patients who are diagnosed with major depression eventually are diagnosed with bipolar. So when I screen for major depression, I don't screen just for major depression, I screen for mood disorder. As I'm going to transition in a bit about bipolar, I do screen for bipolar at the same time. And that's something every clinician should be doing, mental health clinician, because the impact of bipolar, the treatment is very different than depression. And actually the risk of suicide from bipolar, and I explain that in a few minutes, is significantly higher and with bipolar compared to depression. So here are some of the factors for recurrence versus a single episode of depression. I've outlined some of these, and I'm not gonna go too much into details. By the way, these slides I'm gonna provide to Samnang, and he can distribute. I didn't do it this time, but I'll do it after this presentation. So it's, you know, if I don't go over something or people needs to refer back, so you'll have the copy of my notes. So what I wanted to go over is get a flavor of the major depressive illness, because first of all, you know, I'm going to say this: every depressed patient is different, and that's the beauty and the interest that drew me to psychiatry as opposed to other field of medicine. You know, I don't know how many different type of infection or heart attack or a stroke one can have. There are certain variety, but with depression, there's a story behind every individual with depression. So the flavor of the presentation is very dynamic and very different with every patient. But some of these are some of the features that can present with any major depressive illness. So sometimes we qualify major depression with psychotic features, with catatonic features, with melancholic features, if we feel that that's some of the features that predominates the presentation, in addition to the criteria that I mentioned for a diagnosis of major depression. So with psychotic features, major depression with psychotic features, sometimes patients who are severely depressed can experience psychotic features such as feeling paranoid, having perceptual disturbances or hallucinations. So some people who are depressed can start hearing voices, can start seeing things that are not there, can start becoming delusional. Also, not just paranoia, but sometimes they feel they can develop persecutory delusions, so feel that, you know, there's a plot against them, the government is after them, you know, is plotting against them. There's all kind of delusions. Sometimes people, you know, believe that their significant others are cheating on them, and just because they're in a depressed state. So certain psychotic features can present, and also including psychotic features can be disorganized thoughts and behaviors. So some patients really can't, in a normally a patient or individual who's very organized and very on task with their daily activities may suddenly you know, present with very disorganized thoughts and behaviors. So major depression with catatonic features. So catatonia is usually described as a motoric immobility. So usually they tend to be frozen, so to speak, or move very slowly. And sometimes it's the opposite. They tend to move a lot. So there's catatonia, who can also present as a very agitated patient, which is actually a psychiatric emergency. That's something we have to address, making sure the patient doesn't injure themselves or others in their surroundings. Sometimes with catatonia, people can present with echolalia or echopraxia. So echolalia means they tend to repeat. After themselves or after somebody else. So someone will ask me, how you doing, doc? And a depressed patient, if I was depressed, I would say, how are you doing, doc? Or someone will raise his hand and the person will raise their hand at the same time. So there's a mimicking of verbal or physical output. With melancholic features, usually melancholia means a pervasive loss of pleasure, of lack of reactivities, meaning their affect is very flat. They don't show any emotions. They don't smile. You can see the sadness in the face, so to speak, and in their body posture. So they may be stooped in the body posture. They may move very slow as part of melancholic features. With atypical features, with depression, major depression, it's usually some of the opposite of what we would expect, some opposite symptoms of what we would expect with major depression. So as I've said before, patients with major depression tends to lose their appetite in general. But with atypical features, they tend to eat more and gain weight as a result and not lose weight. Instead of sleeping less, they tend to sleep a lot. And there's this terminology, what we call Laden Paralysis, as part of atypical features of depression. They tend to sort of feel very heavy in the body, in their movements. So their arms and the legs, you know, they tell you, doc, I can barely move, you know, I can barely get out of bed. And that's part of this latent paralysis. That's part of major depression. Then we know also postpartum depression usually occurs within 4 weeks after delivery of the baby. So one has to screen, and because there's significant hormonal change after delivery or during pregnancy, obviously, and after delivery, there's a shift in hormones that happens in a woman's body. And certainly with that, depression can ensue as a result. So one has to closely monitor patients, or what we call the baby blues, which is a normal sort of expected response. And again, one can move from baby blues to postpartum depression to full-blown major depression. So it's all a spectrum of continuity and severity of symptoms, and how long the symptoms last, and how much dysfunction they can cause. Certainly, there can be a seasonal pattern to the presentation of depression. And there's something we call Dysthymic Disorder, which is what I consider low-grade depression, but for a long time, i.e. for at least 2 years. So what we know, I'm not going to go into too much detail, but this is sort of a brain present graph of a picture of what we think depression is stemming from medically. So we know certain areas of the brain control our mood. So for example, the limbic system is the main region where we think depression symptoms come from. And that includes several areas that I'm not going to go into too much details, but these 3 areas are implicated biologically in depression. So it's not that we don't know where it's coming from. We know exactly where it's coming from, what part of the brain it's coming from, and what are the neurotransmitters that are causing depression or the lack of. So we know for the main players in depression are serotonin, which is the main neurotransmitter that regulates mood, hunger, sleep, impulsivity, and cognitive processes, sexual functions as well. So certainly it is the main neurotransmitter that's implicated in depression, in anxiety, eating disorder, and pain syndrome. And the mainstay of medication is geared towards restoring or modulating those neurotransmitters. Norepinephrine is another neurotransmitter that plays a role in maintaining mood, energy, interest, and motivation. And dopamine is another one that sort of tends to helps to regulate mood, motivation, also the pleasure centers of part of the brain that senses pleasure and reward. So, for example, that's a main neurotransmitter that's affected by many drugs, such as methamphetamine, cocaine, impacts the dopamine system. So the whole idea with depression, there's, just to make it simple, but there's low level of these neurotransmitters in these parts of the brain that I mentioned before. Okay, so how do we treat depression? There's really 3 phases that a psychiatrist would focus on. One is the acute stage, which usually is within about 3 or 4 months, usually where we are gonna actively treat the symptoms with medications, with therapy, with other allied health components to treat the patient who's very depressed. Once after about 6 months or so, then they reach, let's say in the graph, they do get better. This is the acute phase. And after 6 months here, technically, if they get better, they under remission. However, they are still at risk for relapse 6 months after. So the accepted standard is to continue treating after remission to make sure that the patient does not relapse again. So for another 6 or 12 months, we want to maintain medications, therapy, and other modalities of treatment to make sure the relapse does not occur. After about 6 to 12 months, if the patient is going to relapse, now we call it recurrence. So, so it's usually, you know, after 6 or 12 months, the patient is at risk for recurrence. So that's why we tend to maintain treatment for long term. Now, if a patient, let's say, is better and symptom free after, let's say, a year, then yes, I would try to reduce the medication or therapy or anything else, you know, see if the patient can do okay with less medication or less therapy for treatment. I'm not going to go into details about every antidepressant, but these are just some names that anybody could come across as far as depression. There's different class. And remember, I talked to you, I mentioned the different neurotransmitters that are implicated in depression. And these are some name of the medication that are belong in that class. So SSRI stands for selective serotonin reuptake inhibitors. And basically what they do, those medication is increase the level of serotonin between the brain cell, therefore helping depression, alleviating depressive symptoms. SNRIs are things like Effexor and Cymbalta. Those are selective norepinephrine reuptake inhibitors. They basically increase the level of serotonin and norepinephrine between the brain cells. DNRIs are dopamine norepinephrine reuptake inhibitors, so things like Wellbutrin. Those increase mostly dopamine and norepinephrine between the brain cells. And these are the tricyclic antidepressant and what we call MAOIs, monoamine oxidant inhibitors. Those are different class of medication and that work by different mechanism. So again, that's why I refer to the effect of treatment. It's not, because a lot of patients say, well, how do you treat depression? How do you know the medication work, And we have it down to neurotransmitters. So we know exactly what happens. So for example, I'm not picking on serotonin as the main neurotransmitter, but obviously I've told you guys there's also dopamine and norepinephrine and many other neurotransmitters. But let's say serotonin, this is a normal brain cell. We all have serotonin to regulate our mood, but it's released between the synapses or between the two brain cells. What happens with all of us is we reabsorb these neurotransmitters just as recycling those neurotransmitters. That's a normal mechanism that happens for all of us. Just like all of us are mindful in recycling to be better for the environment, biologically, our body does that, our brain does that. So if a patient is depressed, they tend to have low level of neurotransmitter between their brain cells at any one time. The strategy with the mechanism of action with most neurotransmitters is to block that pump that reabsorb the neurotransmitter. Therefore, at any one time, the more neurotransmitter is going to be present and be able to impact the receptors at the other end of the brain cell. Therefore, increasing the level and the activities of those neurotransmitters, therefore improving depressive symptoms. I have a lot of questions with antidepressants. So, some patient ask me, hey doc, I don't want to take any of medications because I've heard that people want to commit suicide from taking antidepressant. There is a black box warning, but usually it's black box warning applies to children and adolescent and young adults, usually below age 24. That does not apply to regular adults. So, although it can be part of symptoms of depression, again, suicide, usually it's not caused by the medication in adult patient. Certainly child psychiatrists have to be a lot more, young adult psychiatrists have to be more vigilant in making sure when prescribing antidepressant that the risk of suicide is not increased by the medication as opposed to the illness per se. Okay, so let me make another mention of FDA indication. So just because I've mentioned a lot of different indications here for different medication, just because one medication has the FDA indication for certain specific disorder, such as major depression or other anxiety disorder, doesn't mean that others are not as good or efficacious in treating the symptoms. What the medication reached the FDA indication because they submitted their studies and they got approved for it. It doesn't mean that another medication who did not go through a trial is not as effective. So I get a lot of questions saying, how do you know one medication is better than the other? I don't know. It depends, just like I explained to the patient, which medication is going to work for me, doc? I don't want to be an experiment and take every medication. So I don't know. So the same thing is, if someone asks me for a soda, my next question is, what kind of soda do you want? And then, okay, he says, we want a Coke or Pepsi. So I don't know. So any of those could be equivalent and work as well. Same thing with antidepressants. So it's very subjective, but also it requires monitoring by the psychiatrist to make sure that the patient is tolerating the medication and is benefiting from the medication. So other indication of antidepressant can include any of this. So a lot of anxiety disorders are antidepressant or the first-line treatment for many anxiety disorder, panic disorder, chronic pain symptoms, diabetic neuropathy, bulimia, obsessive compulsive disorder, PTSD, post-traumatic stress. First-line treatment is with an antidepressant. And I'm just talking about medication, but obviously, I've always said in my presentation, medication is important, but not any more important than therapy and other treatment modalities. Smoking cessation, Wellbutrin or bupropion is an antidepressant that has been shown to help with people to stop smoking. Or it's called, for smoking cessation, it's called Zaban. It's prescribed by a primary care doctor, but technically it's an antidepressant. So these are I'm going to shift gear and talk about therapies just for a minute, but these are therapies that are being used by therapists, and all psychiatrists are trained have certain amount of training in therapy. Even though it's not our specialty, our bread and butter, but we're all doing our training, our medical training, our psychiatry training. We've have a year long to learn about therapy and to provide therapy to our patients during our training. And we continue doing that. And nowadays, the mental health is divided between therapists and psychiatrists. So I'm not going to go into details into every one of them, but I just wanted to give this as a reference. And I also provided other treatment modalities, ECT, electroconvulsive therapy. I've done some ECT for very depressed patients. It's actually a very effective treatment for severe depression, and is underutilized by psychiatrists. And just because it's more costly, it involves, we need to have an anesthesiologist, or it's a procedure. It could be a daily procedure, but it's a fairly intensive daily clinic appointment that needs to be made, and the patient has to be anesthetized by an anesthesiologist in order to give ECT. Okay, let me switch for 5-10 minutes on bipolar, because I'm not running out of time. So bipolar disorder is the prevalence is about 1%. So it occurs a lot less than depression. But we have to, as any mental health professional, should always screen for bipolar. It's equivalent among males and females. The onset age is younger than major depression. So the average age is 19 or 20, as opposed to 29 or 30 in major depression. Is usually similar across all ethnic groups. It is not usually associated with downward drift. So what I mean by downward drift. Patient with mental illness, severe mental illness, like schizophrenia, tends to fall socially behind. And as they get sicker and sicker, they tend to not care for themselves as much. They tend to not seek help and not receive the help. And so they sort of drift socially, economically, and in every way in society. Bipolar don't experience that, unlike schizophrenia. Here I highlighted the complete suicide rate up to 15%. So which tends to be higher than depression. And the analogy I like to give is, with a patient with bipolar, once one has experienced the very high and the very low, once somebody becomes suicidal, the height of the depression is much more significant. Just like if you climb a mountain top, the fall is going to be much more severe when somebody experiences depression. So suicide is much more intense with bipolar patients, and the completion is more than major depression. We all know some bipolar patients who committed suicide. Can't remember the comedian. It's not come back to me, but who committed suicide, but very, very, very patients who have bipolar are well known and have committed suicide. So there's a high association with bipolar with multiple areas of dysfunction, including divorce, occupational problems, just it's academic problems, artistic problems. So usually patient with bipolar tends to be very creative and very productive, but certainly, when they go into a depressed state, then, it can impact many areas of their functioning. There's a very strong comorbidities association between bipolar and substance use. Again, the need to screen a patient before diagnosing a patient with bipolar for substance use is critical. So a patient who actively uses cocaine and meth and can present as manic or bipolar-ish. And so I need to rule that out and see, long-term how, technically I cannot diagnose a patient bipolar if they recently or actively using drugs. So I need a period of significant abstinence from drugs or alcohol to be able to diagnose bipolar. Usually bipolar is described as extreme high and extreme low of moods. So very high mood and very low mood. Just like depression, it tends to be chronic and recurrent. There also can be a seasonal variation. Usually depression lasts longer than the manic or the high mood episode. And I'm gonna go over those symptoms of bipolar. And again, I always screen for bipolar when evaluating a patient with any mood disorder, depression, and any psychiatric disorder. And I can't emphasize enough the need to rule out substance use. Okay, so bipolar disorder diagnosis requires at least one episode of what we call mania or hypomania. And those are, mania is described as an elevated, expansive, and irritable mood. So usually patients, the way I ask this is, have you ever experienced what I call the opposite of feeling depressed, feeling extremely, extremely happy, euphoric, feeling on top of the world, or extremely irritable, angry for no reason? And then you sort of go into a depressed state or, on any given day or within the same day. In addition, there has to be three other symptoms that accompany this elevated mood. So inflated self-esteem or grandiosity. Patients who are manic tend to be grandiose, meaning they think they are better or they can accomplish more than they in their normal state. Or sometimes people feel that they're extra creative or they're geniuses when they're in a full manic state, or they have some kind of foresight or prediction that they're gonna resolve or the world problems or come up with an invention. Usually sleep is the first thing that goes with bipolar. So my first thing with early symptoms of screening patient bipolar is sleep. When the patient with a mood disorder with bipolar disorder start losing sleep is the first thing that goes. So the patient tends to sleep less and less every night. And usually just we experience, any one of us, I've had days where I didn't sleep because of whatever stress I've had. The next day, you sort of past the point of being tired, and your thinking tends to be sort of off, and certainly your mood tends to feel kind of giddy or irritable. So we all experience some degree because of sleep deprivation, but certainly that is heightened in bipolar disorder. Patients with mania tend to talk more. They tend to be very talkative, so much so that it's very hard to stop them. They tend to speak very fast, and it's very hard for them to stop speaking. They have what we call rapid or pressured speech. They tend to have racing thoughts. So either thoughts going so fast in their minds, or they tend to jump from topic to topic. So when you see a manic patient, I know clinically, because I've been doing this for 2 decades or so, I know when the patient is sort of manic, because I get sort of this increased anxiety as I'm interviewing the patient, and they tend to be all over the place. They talk about the weather, they talk about the family, they talk about the next topic, and it's usually very hard for me to pace them or to organize the thoughts, or for me to interject and organize my interview, just because they're just they're just all over the place. They tend to be easily distracted. They tend to usually be more engaged in activities, so they tend to feel very productive. So whether it's or creative, or they want to at work, they feel that they can accomplish a lot more. And in reality, very, very little gets accomplished. In their mind, they just set on doing so many things, but they're so disorganized and jump from one task to the other that really they're not effective in their goals. There's again marked impairment in functioning, or hospitalization, or psychotic features that is present to be diagnosed with a bipolar illness. And this is a mnemonic, again, that we use to elicit this criteria when screening the patient for bipolar. The clinical picture, I sort of mentioned it as I went along with the criteria, as far as how I would question the patient for any of these symptoms. The type of bipolar, I've mentioned those. So for example, mixed episode, a patient can present at the same time with both manic and major depressive symptoms. So they don't have to be one or the other. They could be both at the same time during a 1 week period. So that's what we call a mixed episode. A hypomanic or low manic episode usually is a duration. Instead of 7 days, it's 4 days duration. Instead of 5 symptoms or more, it'll be 3 symptoms. And usually they don't, hypomania, which is subthreshold mania, does not cause impairment in social or occupational functioning. Then we have bipolar 1, which has to have at least 1 manic episode, plus or minus, meaning a depressive illness does not have to be present. So they just could be normal, and they could normal mood, and they could experience a manic episode. Bipolar 2 is usually hypomania plus a severe or major depressive illness. And then you have everything in between. So when I don't really know and whether a patient meet criteria for bipolar 1 and 2, a lot of times I do diagnose patients with unspecified bipolar disorder. But better to do that than not screen for bipolar. If I think they have bipolar, I'm gonna go ahead and specify at least an unspecified bipolar disorder. Cyclothamia, which is sort of fluctuation between the subthreshold mania or high and the subthreshold low or depression. And then rapid cycling, usually a patient have to have 4 manic episodes in a year. So my last slide before I end is, but second to last slide is bipolar treatment. Again, we need to assess, I need to assess always for other medical conditions and substance use. So for example, the common medical conditions that can affect mood is thyroid problems. So as psychiatrists, we always order a thyroid function to make sure that's not influencing the thyroid. Obviously, everybody knows it's a hormone produced by the thyroid gland in the neck and the throat can influence, among many things, metabolism, but also influence the mood. Mood stabilizers are usually the mainstay medication, as opposed to antidepressants. So I want to differentiate that with depression. So if a patient is bipolar, if I'm convinced he has bipolar, I'm gonna try to avoid at all costs an antidepressant first. And the reason I'm saying that is because antidepressant actually can make a patient worse and can precipitate a manic episode. So it's counterintuitive, because if a bipolar patient comes in and says, "Doc, I'm feeling super depressed, but if I get any symptoms that clinically suggestive of bipolar, if I give the patient an antidepressant, I elevate the mood, but instead of the mood staying here in the middle, I'm gonna push them to the top, and I'm gonna cause them to be more manic and possibly become suicidal as a result." So the treatment is geared towards a medication that sort of evens out the mood. So brings the high to a normal state and the low to a normal state. And those medications are very different than antidepressant. Again, I want to avoid any medication that that can destabilize the patient's mood. The typical one is steroid. So it's a case example. A lot of times patients who have bipolar go on steroids for an infection or whatever the primary care prescribes steroids, and then they end up in the hospital because they've gone into a full manic state, and they engage in behaviors that are risky. Oh, that's what I forgot to mention about bipolar. They tend to engage in manic state, engage into very risky behaviors, whether it's using drugs, speeding on the freeway, spending spree. So manic patient may spend all their money and go broke, or spend credit cards and get in trouble, usually with the law. So somebody speeding and not stopping, even after a police stops them, tries to stop them, they go on the chasing highway speed pursuit, just because they sort of in the manic state. Again, their thoughts and the mood is so heightened. The last slide is, I'm not going to go into details, but again, it's pointing out to mood stabilizer, which is a gold treatment for bipolar. And again, none of these include antidepressants. So lithium and Depakote are the two medications that have are the gold standard for treating bipolar. I've including other ones down here that we use to treat patients with bipolar. So we have about 15-20 minutes. I want to end here and take some questions. Samnang, I think can you look at the question you gave me by email? Let me stop my sharing. Oops. Sorry.
And while Sam looks that up, I will just remind folks that we should thank Dr. Ngo for today's presentation, which I have to say is very timely. We're really all dealing with a lot of the content that you've shared with us today with our clients and our communities, and very, very timely presentation. And if folks have additional questions, please put those in the chat box, and we can, Sam can ask those, and we can get some of your things answered.
Okay, I'll turn on my screen. So then, were you able to pop the question? I just wanted to answer that question before I take any more question. Let me see.
I'm checking at the moment.
Okay, I have it.
You have it? Okay.
Yeah, I have it. So somebody asked, a client asked, quote unquote, if someone has been diagnosed with a mood disorder from one doctor, and they don't think it's correct, do you recommend they get a second opinion? So that's the first question. And the second question is, do their medical records move along with them, or can they avoid that in trying to get an unbiased second opinion on their mental health? Okay, so let me try to answer the first question. So every clinician, so let me start with answering this question. Every psychiatry is more an art of medicine, just like a surgeon gets crafted in doing certain surgery and procedure, gets good at it. Same thing with psychiatry, to be able to diagnose and treat the patient. It's more an art form. Obviously, I've talked about some of the criteria and some of the diagnosis criteria that we use. But certainly, to come to a clinical diagnosis requires, different interpretation of the data that's presented to us. So, would I recommend a second opinion? Absolutely. Every psychiatrist and every clinician actually differ in their diagnosis. So it's the same patient because everybody has different threshold, and like I said, it's an art. So everybody may come with different diagnoses. So even the psychologist, a lot of time I encounter psychologists who give different diagnoses, and the idea is ideally is to reconcile those diagnoses for the patient's sake. And so what I do with psychologists, if we have different diagnoses, the psychologist could reach out to me and say, hey, Dr. Ngo, you saw the same patients. How'd you come up with bipolar? Or I came up with only major depression. How'd you come up with bipolar? So it's more of collaborative approach that we try to work among each other in mental health. Now, with that being aside, if the patient is not satisfied or with the treatment or with an evaluation by a mental health professional or by a psychiatrist or a psychologist, absolutely, I would tell the patient, get a second opinion from someone else, just like any other medical specialty. Get a second opinion for surgery, for dental procedure, if it's you are the guardian of your health, and only you can advocate the best for your health. So I'm all about getting a second opinion. Now, the second question is, do their records move along with them, or can they avoid that in trying to get an unbiased opinion of their mental health? So it depends on the system when one works on. So for example, if one works in Kaiser, I'll just give an example. Most medical records within the system is shared among all providers. So whether it's social worker, a primary care doc, or a psychiatrist or psychologist can see all medical records of the same page of the patient. So it depends if one chooses to look in those records or whether those records are accessible at the time of the evaluation. So I work in a system now where a psychologist also assesses a patient separately from my initial evaluation of the patient. A psychiatrist also has previously assessed a patient. Do I check the records? I do not, and because I want to be as unbiased in my evaluation as much as possible. So I start from scratch. The only thing I do look, and this is for continuing care, is if a patient is on medication. I'm just saying as a psychiatrist, if a patient is on medication, I want to know what did the last doctor do with their medication to treat the symptoms, so I can continue the care and assess and then move it and make changes accordingly. That's the only thing that I check. I don't even read other psychiatrists' notes in details. I do not read other providers' notes. Should I, if I had time, all the time in the world? Yes. But I've always, trained myself through the years to form my own evaluation and trust my clinical instinct and my training in coming up with my own diagnosis separately. And I always say a mental health provider, whether a psychiatrist or licensed social worker or psychologist, practice with their own license. So one should be able to stand on their 2 feet if something bad, if a bad outcome were to happen. So let's say in court, the patient ended up committing suicide. I would never stand in court and say, well, I because the other doctor said that the patient never committed suicide. That's why I didn't ask. So I always go unbiased and in providing a first or second opinion. Did I answer the question, Samnang?
Yes, we gonna say yes because I have not knowledge on that. But we do have one more question, Dr. Ngo. The question is, what kind of holistic alternative approach would you recommend for someone with a mood disorder?
Oh, every approach that we talked about when we did, I think I did my first presentation on treating mental illness with allied health. So yoga, therapies, and I always said this, medication is only part of the treatment, and so last resort in my eyes. It depends on severity, but I have to be prepared. But certainly, I always emphasize to the patient, medication is only going to do so much. You got to do your part and access other modalities of treatment, whether it's therapy, work with the therapist, and do anything you can do that you can engage with, whether it's yoga, whether it's meditation, whether it's breathing techniques, any other modalities that, or even exercising. I do promote, I do talk quite a bit with patients about exercising, about nutrition, because we know nutrition does impact mood in general. Patients who are depressed, some patients, if they gain a lot of weight or have lost a lot of weight, I need to talk to them about nutrition. So I do that. So all of these, I do talk to patients every single time. So it's not, very little of my assessment actually is talking about medication. I save the last couple minutes really because that's fairly easy. And then when I engage in treatment with patients, I always ask, not that I don't know, I say, Samnang, so you're taking those medications, what do you think we should do? What do you want? And then I sort of said, and it's this mode of treating patients and offering and engaging the patient in, that's your treatment, Samnang, not my treatment. So I want you to be involved. Tell me where you want to go. I'll tell you, what's possible. That'd be, well, give me marijuana, I have a lot of patients say, and I said, well, even it's legal, I don't have a medical license to prescribe marijuana. And it's, it's still a hot debate in the medical community. But, I do give boundaries, but a lot of times I try to give the power to the patient and then guide the patient in their treatment. So I will tell them, if they say, well, Doc, I'm feeling depressed because your medication caused me to gain 50 pounds in the past month. Obviously, I'm going to talk to them. The first thing is, what can I do with medication to try to decrease those risks or switch to another medication that is effective in treating your depression. But yet, if you have so many side effects and if you're gaining so much weight on it, I need to address that. And then I'm also address, other ways to lose weight besides medication, my medication management, i.e., exercising, i.e., watching the diet or fasting or anything, or, so I try to give a comprehensive education to the patient and not talk just about medication.
Mhm. To me, it sounds like the best medicine is no medicine. You always have to try the alternative holistic way. Exercise, watch your diet at first. That's the main goal. That's seem pretty good. We
Yeah,
do
and,
have
and as much as I medicate, sorry to interrupt, but as much as I medicate, I actually take a lot of patients off medication. And I always tell the patient, my goal as far as medication is to treat to treat your symptoms with the least amount of medication possible. Sometimes nothing, but some patients, unfortunately, because of recurrence and because of severity of symptoms, you know, I always try to decrease medication if I can, and then substitute that with, if I decrease medication, I always said, you got to do more on your side, whether it's therapy or other treatment modalities, to compensate for that. And if I see that there's a recurrence of symptoms or the symptoms get worse, then we'll have a talk with, I'll have a talk with the patient saying, well, we try to decrease the medication, something's not working. So either we have to maintain the medication until you can compensate with other modalities of treatment.
well, we have about 5 minutes. We're gonna go ahead and do one more question and we will have to end the session. The question is the 50% recurrence of MDD in patient without medication?
It depends, because treatment, it varies, and then I cannot tell how many of that percentage actually are engaging in medication plus therapy combined. So, but the recurrence is higher after, like I mentioned that slide of a phase of treatment. Usually after 6 or 12 months, you know, the chance, if the symptoms recur, they're gonna recur after 6 months of treatment. Once we pass the acute phase of treatment, then if the symptoms are still very present and significant and causing impairment in functioning, then I have to consider recurrence or relapse. So I have to treat for that and continue maintaining treatment. So that's why that's a problem with a lot of patients, because they get better, let's say after 3 months, and they say, doc, I'm better now. Well, I'm saying, well, maybe you're better because you're on medication and you're getting therapy and you're getting all the treatments. So, you know, and then they're quick and saying, well, I want to quit everything. I'm better, I don't need anything. And I say sooner or later, unfortunately, the natural course of the illness for the majority of patients is a chronic and recurrent illness. So I'm not saying you're gonna need to be on medication and on therapy for the rest of your life, but you know, the goal is to minimize any of those treatments should you feel better, and do that in gradual step and reassess and see how much one can tolerate and continue on improving down to nothing. But that should be a gradual approach rather than stopping everything all at once. Because then the risk of relapse is every episode 50% after one episode, and it increases 60-70% after 2-3 episodes, down to 80-90% after 3 or 4 episodes.
Well, thank you, Dr. Ngo. And before we end the session, please don't forget to help us complete the survey. It's in the chat box. And I would like to say thank you to the lawyer and Dr. Ngo for a great presentation today. I have generated a lot of information. I need to process it. It's very, very a lot. So it really helped me to understand more about mental health and the mood and the differences. So please do the surveys, and I would like to everyone to give Dr. Ngo a hand of applause, and thank you. To see him next month again.
Thank you. We'll see you then.